Today's session is titled Ethics, Empathy versus Compassion. Let me actually turn on my video so you can see me as I talk. Empathy versus compassion. And it will be given by our lovely speaker for today, Dr. Heidi Mattison. And I'll be the chairperson for today. So I didn't even introduce myself. So I'm Nabisa Mlandu. I'm a neuropsychologist and a master's student at the Ethics Lab, where Heidi is also supervising me. Okay. So thank you so much to Blood SA Foundation for today's talk. So today's deep dive is brought to you by Blood SA and the University of Cape Town. And it's in strategic partnership with SAFAS and the South African Stem Cell Transplant Society. Yeah. Okay. And thank you so much to the deep dive management team for putting all of this together. Thank you to Prof. Stel Verburg, the team leader, Dr. Gerdien Kritzinger, the national training coordinator, as well as the lovely Dr. Nicole Smith, who is here today with us, the National Outreach Officer. Okay, so before we start, some housekeeping notes. So all our sections are recorded and can be found on the Blood SA website. Just click on resources and then go to deep dive. And for today's session, please feel free to add any questions or comments to the chat box during the meeting as we proceed, and we will respond to them at the end of the presentation. So I'll keep track of all of those questions or comments that you add there. And in terms of CPD points, very important, they'll be submitted to the HPCSA for each person that registered. Please just ensure that you are using your own registered Zoom link, not in a group, and attend for at least an hour to actually get the points, and ensure that your HPCSA number was entered correctly when you signed up for deep dive. And if you have any issues later, you are free to email the admin at bloodsa.org.za. Okay, moving on to the mailing list. So you're welcome to join the mailing list via the website. You can just click resources, subscribe to deep dive, or use this QR code. And we really appreciate your feedback. So please do complete the anonymous feedback survey at the end of the Zoom meeting. So yeah. So this is the agenda for today. So this is the agenda. Sorry, I think someone.
All your courage.
Okay, sorry, someone was unmuted. So today's agenda will be a talk by Dr. Heidi Mattison. Then we will have a Q&A after that. And then it's the closing. So yeah, fairly straightforward. Speaking of Dr. Heidi Mattison, I am happy to introduce Dr. Heidi. She trained as a moral and political philosopher. She is employed as a senior lecturer in bioethics in the ethics lab based at the Neuroscience Institute at UCT. She's also an honorary research associate at the University of KwaZulu-Natal. And the central theme of Heidi's work is to think and enact care in the context of the academy. She'll speak more to this during her talk. As a philosopher, this means conceptualizing and understanding care as an essential component of what makes us human. As an academic teacher, this means thinking deeply about how to structure a bioethics curriculum to learn and develop, while also being supported to make sense of the ethics of our world. As a bioethicist, it means advocating for the integration of perspectives from care ethics into how we think about and address ethical challenges. So it also means working alongside healthcare providers to understand the importance of care in building ethical resilience. So as you can see, Heidi wears a lot of hats. So We're excited for today's talk. Please, Heidi, take it away.
Thanks very much, Nobita, for the warm introduction, and thank you again for having me here at the Haematology Deep Dive. While I share my screen. Right. I think, I hope everyone can see my screen. I want to start this talk, The Cost of Caring is Empathy Breaking Healthcare, with an extension of gratitude to the two people who independently kind of inspired this talk. I was 2 years ago, I was at a Southern African HIV clinicians conference, and I was talking about care and compassion and empathy. And one of the audience members described a situation where she felt that she had compassion fatigue. And she talked about this experience and asked me if I could help her. And I have to say, I had very little that I was able to say in response. I could tell her academically what I thought, but I wasn't able to kind of offer her the psychological and resilient support that she needed at that time. I was recounting that story to my third year medical MBCHB medical students, and one of the students said, if caring causes compassion fatigue, should we perhaps stop caring altogether? And both of these moments, the over-caring and the person talking about under-caring, really resonated with me and have inspired the work that I've done subsequently in the last 2 years, where I've started to think about the relationship between care, empathy, and resilience. So I hope that I offer you something helpful throughout this talk. We're going to start with some audience participation. I know everyone loves that, but you have to work hard to get your ethics points today. So I'm going to give you a couple of scenarios, and what I'd like for you to do is to use your emojis, your reactions, if you can, to show me which of these two you would resonates more with you. So thumbs up if it's the first one, and clap hands if it's the second one. So imagine you have a patient who is visibly tense and they complain about waiting 2 weeks for test results. Do you say, I can see you're concerned, let me explain what's happening with your results and when you can expect them? Or do you say, I understand, waiting for news like this can feel unbearable? So if you are able, I'm not sure if reactions have been allowed. Okay, yes, they have. So you can put it in the chat or you can just react on the screen. But as we go through, I'd like you to just think about these in terms of whether you're a thumbs up person or a clap hands person. And I'll do the next one for you as well. Warm you up. So the next scenario we have a young mother arrives at 3 a.m. with her toddler who has a high fever. She's clearly worn out and starts to cry as she explains she hasn't slept in 2 days. Do you say, this must be so hard for you right now. I can see how worried you are. Or do you say, you've done the right thing bringing him in. Let's get him checked so you can both get some rest. We have a shy audience here. Okay, and let's move on to the third scenario. A patient is told their cancer has returned and is now terminal. They say, I don't want to die. Do you say, I hear how much this frightens you. Let's talk about what matters to you now and how we can support that. Or do you say, I can only imagine how difficult this is for you to hear. So what these little scenarios and these kind of somewhat obvious responses are indicating is really the difference between empathy and compassion, which I'm going to talk more about as we progress. Before then, I just want to go through what we'll cover today. So some definitions, which I've started with, some neuroscience, and only a little bit, and Rabisa's the expert here, so she'll be able to correct me when I get either the pronunciation or the description of the brain wrong. I'm going to give you some context, then I'm going to hit you with some philosophy, and again, I promise only a little, and then I'm going to make some suggestions. And I hope to leave space for some conversation and some questions or comments at the end. So it's important, I think, as a philosopher, we always start with definitions to try and understand what we're talking about and to ensure that we're not talking at cross purposes. So empathy can be defined in a number of ways, but there is a common thread to it. So it could be feeling what others feel, the ability to share someone's feelings, the ability to walk in another's shoes. It's experienced as an effective response that acknowledges and attempts to understand individual suffering through emotional resonance, experiencing other emotions, or trying to understand or place oneself in the situation of another person to be in the mind of the other. In contrast, compassion involves caring about what others feel. So not feeling what they feel, but caring about what they feel. It does involve a deep understanding of the situation, but also a basic sense of caring about the suffering of others and oneself, being sensitive to it and intending to prevent it. It's about feeling concern for another's suffering. It's about trying to address the suffering and needs of a person. It's about wanting others to do well and not suffer. And it's a state of concern for the suffering or unmet need of another person, accompanied by a desire to alleviate this suffering. Now, Sinclair and colleagues in 2017 conducted a series of interviews with patients who were in oncology units, and they described their experiences of the difference between empathy, compassion, and sympathy. And they described empathy as where you put yourself in the person's shoes and you would try to imagine yourself walking in those shoes and how you personally would react. They say when you empathize with people, you've crawled right into their moccasins. And they think that empathy is the ability to be able to communicate on a visual, physical, whatever level and make a connection. But there's also a sort of deep understanding of the situation and this sort of thing. They describe compassion as actions, whereas sympathy are thoughts and well wishes. Someone said they think empathy is more of a feeling thing when you're aware of somebody's suffering, and compassion is when you act on this knowledge. Sympathy are words, and you know, geez, I hope you feel better, and it's terrible you got this. And compassion is running over and getting a bath bag. And then apologies for the swearing, but if you're thinking of looking for sympathy, you'll find it between shit and syphilis in the dictionary. And lastly, sympathy, I think you're feeling sorry for that person. I don't want somebody to feel sorry for me. I want you to help me. And so I think the words I've made in bold really highlight the difference between empathy and compassion, whereas empathy is a feeling and compassion is described as having an active component. It's an action, it's running, it's helping, as opposed to feeling or offering words. Now, I want to say upfront that I'm not making an argument against empathy. There is a wonderful book by Paul Bloom called Against Empathy, The Case for Rational Compassion. And he does actually make an argument against empathy. And he describes empathy as being a spotlight which focuses on certain people in the here and now. This makes us care more about them, but it leaves us insensitive to the long-term consequences of our acts and blind to the suffering of those we do not or cannot empathize with. And so I'm not making an argument that we shouldn't be empathetic. I'm rather making an argument that we can no longer afford to be as empathetic as we perhaps might like to be because of the context in which we find ourselves in healthcare generally and in South Africa specifically. Now, to make clear what this point is about the empathy being a spotlight focusing on certain people, I'm drawing on Peter Singer's 1972 thought experiment about saving children. And Peter Singer is a famous utilitarian philosopher, and he suggests that empathy can narrow our gaze. And so he gives the example of you walking past a river in your beautiful suit and you see a child drowning in the river. And the question is, do you jump into the river and save the child, even though it's going to cost you your $1,000 suit and your suit is going to get damaged and become unwearable? And of course, Peter Singer says, absolutely, you jump into the river and you save the child, because the life of a child is much more important than the life of your suit or the value of your suit. And no one would disagree with that, I'm sure. But then he extrapolates from that example and suggests that if you're watching TV one night and you see a child on the screen in a far-flung village that has been affected by floods, and across the screen at the bottom it says, send $1,000 and you can save this child's life, he asks whether and how many of us would get out our phones and make the transfer of $1,000. And what Peter Singer's point is that we are naturally inclined to be able to help those in front of us or those we can identify with. But as soon as there's distance between us and those who are suffering, that desire to help or that ability to help seems to be watered down. And so for Peter Singer, we should absolutely get out our checkbooks and send a check or EFT the $1,000 for the child in the village. But his point is that there are so many other things that come into our minds, like, is the money really going to get there? Is there really a child in a far-flung village? Will my money actually benefit the child? Whereas we can see the benefit of jumping into the river and saving the child immediately. And why I bring this up is to really show you how empathy can act really, really well in getting us to be motivated to help people, but it can also act like a spotlight and put other people with whom we don't empathize or don't identify so well in the darkness, and they don't receive the benefit of our largesse. So why do I say I'm not making a case against empathy, but I'm saying that empathy is problematic in our current context? And I think that all of you sitting here know firsthand the inequality that South Africa experiences with a Gini coefficient of close to 1. We are currently the most unequal society in the world. But what this means in the healthcare space is that we simultaneously have world-leading healthcare possibilities and dire poverty. And this poverty affects the population burdened by epidemics of violence, trauma, HIV, TB, diabetes, and other diseases. So what I'm saying here is that we have world-leading medical training and some facilities that allow us to offer this service to our population. But others, and the majority of those, are chronically under-resourced healthcare public facilities. And compounding this is the diversity and inequality among patients. So the difference between patients and their clinicians is vast, and the difference among patients. So the different cultural, religious, and traditional versus rural and urban and contemporary, and all those differences make for a kind of perfect storm where moral distress occurs. And so I think a lot of this distress can be explained by understanding that our medical doctors, our nurses, our staff are trained to be empathetic, but there is an overwhelming burden on them such that the empathy is now causing a kind of level of distress that is perhaps not seen before. Or perhaps could be described as having been seen in the HIV epidemic in the early 2000s. So just to hit home the point about the the situation in South Africa. An NPS survey a couple of years ago indicated that more than 35% of healthcare practitioners in South Africa say their mental well-being is worse now than it was during COVID. Almost 40% of those surveyed said the impact of burnout and exhaustion on patient safety was impacting their own mental well-being. A quarter of the participants were considering leaving the medical profession or retiring early due to mental well-being concerns, and 22% said they plan to leave or have considered leaving South Africa due to those same concerns. So there is another epidemic, and it's the epidemic of mental well-being in South Africa among healthcare providers. And so if we understand that this is real, it is not shameful, but it is impacting both patients and clinicians, I think it's important that we consider ways of enabling healthcare practitioners to cope better. And what I'm going to be suggesting is that teaching empathy may not be the best way to do this. So I mentioned earlier that my HIV clinician audience member talked about compassion fatigue, and I've been talking to you about psychological distress. And from the literature, there is concern about this term compassion fatigue. Originally, it was described as the formal caregiver's reduced capacity or interest in being empathetic or bearing the suffering of clients. It's often assumed to accompany another version of fatigue known as burnout. And so it can manifest as a result of hard workloads, lack of recognition, and social disconnection from the team. And what this often requires is that the burnt out individual or team has to take time off, which therefore reduces the hours that can be made available to the patients for formal and informal caregivers. So I've painted a pretty bleak picture. We've got a context of patient suffering, of clinician suffering. We've got the possibility of providing incredible care, but the reality is that we're often unable to do that. And all of that compounds together, causing moral distress. Now, what does this have to do with empathy and compassion? Well, in the last 10 years, there's been a lot of advancement in neuroscience in this area, and Singer and Klimecki have produced a really excellent, very short study which revealed how empathy and compassion activate different brain networks. So the empathy network, which is associated with negative feelings, shared distress, and can lead to withdrawal, burnout, and especially in caring or helping professions, is activated in a different part of the brain from the compassion network, which is associated with positive feelings, warmth, and a motivation to help, and can lead to approaching behavior and pro-social action. So the opposite, instead of withdrawing or becoming paralyzed by the level of suffering one is empathizing with, the compassion network allows one to become activated and to develop a kind of active response to the suffering that other people are experiencing, because one does not take on that suffering oneself. So this is also drawn from the article, their first figure, the difference between compassion and what they use, the term empathic distress. So under empathy, we have positive empathy, which is compassion, and we have over-empathizing, which is empathic distress. So compassion is an other related emotion. We think about the person who is suffering, as opposed to when we are experiencing empathic distress, we're imagining ourselves in that position. And so think of how we ourselves would feel with that level of burden or suffering. Compassion motivates us to have positive feelings such as love, whereas empathic distress motivates us to have negative feelings such as stress, which leads to poor health, burnout, withdrawal, and non-social behavior, as opposed to the positive feelings can encourage good health, approach, and pro-social motivation. So really the idea is that it's two different sides of the same coin, one which has a really positive kind of set of outcomes, the other a much more negative one. So I want to talk a little bit more about what we're calling empathic distress, because I want to move away from the idea of compassion fatigue and talk more about empathic distress, which is the over-identification with another person's suffering, and which can have all these negative effects. So Singer and Klimecki say that exposure to the distress and suffering of others can lead to two different emotional reactions. Empathic distress results in negative feelings and is associated with withdrawal. And when experienced chronically, it's most likely to give rise to negative health outcomes. On the other hand, compassionate responses are based on positive, other-oriented feelings and the activation of pro-social motivation and behavior. And so they talk about Erickson and colleagues in 2018 discussed compassion fatigue, which is often self-focused and predisposed of fatigue. But again, they refer to it as empathy distress fatigue, or what Singer and Klimecki call empathic distress. Okay, so we've got two kinds of emotional responses to the suffering of others. We have compassion, which is the positive, I'm arguing the positive pro-social response, and we have empathic distress, which is the kind of over-identification and the taking on of someone's suffering and imagining ourselves in that position, and that becomes too burdensome. If you can imagine, one can empathize and take on the suffering of one person, perhaps a close family member or a dear friend. But as a healthcare provider, when you have so many suffering patients,
And I'm like, 1 point to me, she loved.
if you take on the suffering of all your patients, it becomes incredibly difficult to cope, because it's not one person suffering that you're imagining yourself experiencing. It's 20 or 30 or 50 or 1,000. So that's the picture I've painted. I want you to hold in your minds these two kind of responses to the suffering of others. And I'm going to take you back to the time of Aristotle to suggest that although the neuroscience is fairly new and very exciting, that actually this idea has its roots in a long, long time ago, thousands of years back, in Aristotle's virtue philosophy or virtue ethics. Now, there's no test at the end of this, so you don't have to take it all in. But to put the cheat sheet is in front of you, and basically Aristotle had this idea that we should want to live a life of flourishing, and the life of flourishing entails being virtuous, so being the right kind of person. And he believed that, like many things in life, the right kind of person is a balanced person, a person who achieves the golden mean. Now, the golden mean is really the mean between a deficiency of a virtue and an excess of a virtue. So if I take the really simple example, the mean is having courage. A deficiency of courage is being a coward, and an excess of courage is being rash. So if we go back to Peter Singer's person in a suit walking past a river with a drowning child, a courageous thing would be to jump into the river and save the child. A cowardly thing to do would be to stand on the side and say, oh, I don't want to damage my suit, or I don't want to get wet, or the river looks cold and mucky and I don't want to get in it. And that would be cowardice. And rashness would be to dive head straight into the river if one can't swim, and then end up probably drowning as well as the small child drowning. So you can see how a deficiency of something could lead us to not act, and an excess of something could lead us to act in circumstances where we might want to be a little bit more circumspect. But the mean between them, the courage in this case, is the perfect balance, or what I've sometimes referred to in other talks as the Goldilocks position. Not too hard, not too soft. So fundamental to Aristotle is this idea of happiness. He believed that actually the main purpose, the telos of humankind, is to be happy. And so doing the right thing or being virtuous shouldn't make us unhappy. It shouldn't be a burden. It should be something that we strive to do because it's going to allow us to achieve happiness in the long run. And we achieve happiness through living the virtuous life, and it's long term. We don't have momentary happiness. That's contentment for Aristotle. Happiness is something we achieve throughout our lives. So it's not a brief state, but a continual striving to achieve happiness. And as I said, it's the highest good and purpose of all humankind. And Aristotle believed that all human activity should be directed at happiness. So in other words, we want to achieve happiness. We can only achieve happiness by being virtuous. And we want to be virtuous because we want to be happy at the end of the day. Now, Aristotle described a virtuous person as having certain kinds of character traits or ideal character traits. And these involve excellence or virtue, practical or moral wisdom, and eudaimonia, which is the ultimate end, the happiness or the flourishing that people are striving towards. What is key about Aristotle's argument is that virtues are dispositions, attitudes, or character traits that are developed through learning and practice, or what he referred to as habituation. In other words, we're not born with these innate virtues. We can learn them and we can train ourselves to have more of them. So we can train ourselves to be more courageous. We can train ourselves to be less rash, or we can train ourselves to be less cowardly. But it's only through habituation, the repeated opportunities to be courageous, that we ultimately can develop the virtue that will lead to our happiness. So for Aristotle, jumping into the river once and saving a child is a good thing, don't get me wrong. But it's only if we do a number of things that push us to show and to enact courage that we really achieve this kind of virtue or happiness. So it's not a once-off thing, but a thing we repeat throughout our lives in different circumstances. Now, what's really important for Aristotle is that virtues are connected with actions and feelings. Actions and feelings are connected to pleasure and pain, and so virtues are connected to pleasure and pain. In other words, the more we seek a balance between avoiding pain and overdoing pleasure, the more likely we are to become virtuous. So what this means is that if we have too much pleasure, it causes us to do what Aristotle called base action. So we become hedonistic. All we want to do is eat, drink, and be merry. But the idea is that actually life should be a little bit less hedonistic and a little bit harder, because it's through that hardship, through that kind of hard work that we develop our virtuous disposition. At the same time, we can't avoid pain all the time, because if we avoid pain all the time, we will be prevented from engaging in valuable deeds. So, for example, learning. Not everyone enjoys learning. And so if we say, well, I don't want the pain of learning, we miss out on the virtue that learning or that a sort of learned life can bring us. So it's really about a balancing act between having the right amount of pleasure and the right amount of pain. And if we get that balance correct, we will have achieved the golden mean. So if pleasure and pain are managed well, they are considered to be virtues. And if they are managed badly, they are considered to be vices. So the vice of cowardliness or the vice of rashness, as opposed to the virtue of courage. And as I've said, virtue is a mean. We have not too much and not too little, so we don't have an excess or deficiency. And finally, the golden mean is achieved through practice, which comes through habituation, through constant trying and trying and trying to get that balance correct. So if we get it wrong sometime, that's okay. We can start again the next day and try again the next day. So what Aristotle, I think, leads us to is this idea of compassion being a virtue. And I would like to make the argument that empathy, because of its ability or its tendency to leak over into empathic distress, is in fact an excess of compassion. It's too much compassion. It's a vice because it becomes self-regarding, because it paralyzes us from acting, because it stops us from being able to do something about one's suffering and becomes more about a kind of absorbing, wallowing in another person's suffering. So I think empathy, because it turns to empathic distress, can be considered a vice, too much compassion. And I think detachment, which is often a way of coping with empathic distress, to say, okay, I'm not going to get involved in my patient's life. I'm not going to take on their suffering. I'm not going to imagine myself in their position, is too little compassion. So again, a vice, but this time a vice of deficiency. And I think that although Aristotle wrote thousands of years ago, the virtue of compassion is increasingly being recognized as an essential cornerstone of medical codes of ethics. More recently, Sinclair and colleagues found that it is the greatest indicator of quality healthcare according to patients and families. That is, the impact of compassion extends beyond patients' perceptions, affecting symptom burden, quality of life, satisfaction with care, healthcare provider-patient relationships, patient disclosure, and management of health issues and healthcare costs. It also promotes an enhanced workplace well-being, job satisfaction, and retention. In other words, the opposite of all the factors related to empathic distress and burnout. So I'm trying to make a case, I guess, for the idea that the virtue of compassion, which is somewhere between the vice of empathic distress or too much compassion and emotional detachment, too little compassion, is the Goldilocks position. And it's something that we should be training our healthcare providers to learn about, and it's something we should be thinking about in our own lives as to whether we are achieving that balance between too much or too little compassion. So in terms of the suggestions going forward, I imagine you're all saying or thinking to yourselves, well, that's all very well, but how do we do this? And so I think that if we take Aristotle's view that we can be trained, we can train ourselves to be able to understand and enact these virtues, to be able to learn to be virtuous. And we take the neuroscience, which suggests that neural plasticity means we can train our brains to respond with compassion instead of empathic distress. We can really do something about the negative aspects of empathic distress. And in the last 5 years, there's been an explosion in compassion training courses and practices, such that research has shown that mindfulness have indicated reduced activation and structural changes in the brain. It reduces negative affect systems activity, while compassion increases activity of positive brain systems. Compassion cultivation training has been shown to have enhanced compassion skills and reduced psychological distress in medical students, and has shown promising results in an array of people, including medical students, but also physicians, by increasing compassion, empathy, and mindfulness skills, reductions of psychological distress, including stress, anxiety, and depression, and burnout. It's also seen improvements in well-being and emotion regulation, among others. So what I'm suggesting is we take the very, very contemporary work that's being done in neuroscience, the very, very ancient work that was done by Aristotle and his Greek colleagues, and we bring those together to shift our way of training and thinking about what we're teaching and telling our healthcare providers that they should be manifesting in terms of their emotional reaction to patients and each other and themselves. Now, before I think we can practice compassion towards patients and colleagues, I'd like to think about the claim, physician, heal thyself, and talk a little bit about self-compassion. So if we understand that compassion is a construct closely related to mindfulness, or the desire to alleviate the suffering of its causes in oneself and those around us, when we direct compassion towards the self, It's called self-compassion. And I think that that's the starting point. I think so many of the stories I hear about empathic distress are caused by having these incredibly high demands on oneself and these incredibly high expectations of oneself, and feeling that if one doesn't meet those expectations and fulfill those demands, one is somehow a failure. And I talk about this with my medical students because I think they come into the academic space as A-type personalities, as overachievers, and that kind of push to be the overachiever, to achieve everything, to read everything, to know everything, to never have self-doubt, to never be able to feel confident in asking questions, is really an indication that they lack self-compassion. So what is self-compassion? Well, Kristen Neff and Dam in 2014 say that self-compassion involves 3 elements. It requires self-kindness versus self-judgment. So instead of when we make a mistake or when we don't achieve those expectations we have of ourselves, is to be kind to ourselves by trying to understand why it happened the way it did, rather than judging ourselves and telling us that we're a failure or we're bad or other people are better or we're useless or we're inadequate or incompetent. It involves having an understanding of that humanity is in common rather than in isolation. So in other words, understanding that other people too are suffering, other people too make mistakes, and not isolating oneself and imagining that everything that has to be done by one in isolation rather than in collaboration with other people. And then finally, it requires mindfulness over identification. So mindfulness is the ability to be able to recognize the suffering of others, but not take on that suffering of others, or over-identifying with others, imagining what others must be feeling like, in terms of how we would be feeling in that similar situation. Erickson and his colleagues said that self-kindness entails being warm and understanding towards yourself when suffering. Common humanity involves recognition that suffering and personal inadequacy are part of human experience that is shared. And finally, mindfulness, broadly defined, involves paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. And I think that idea of the present moment is really important, because a lot of the work that explains why empathic distress arises is because we not only imagine the person suffering in front of us, but we imagine all their suffering going forward. So what are they going to feel like tomorrow? How are they going to feel like when things deteriorate? How are they going to feel like when they go back home? And that compounding of taking the future into the present, it becomes overwhelming and causes empathic distress. Whereas if we can focus on the present moment, what can I do now about this here in front of me, as opposed to how do I solve the next 5 years or 10 years of this patient's life, becomes much more difficult to do. So I'd like to, as I said, leave quite a lot of room for discussion. I'm going to probably stop there. I know I've given you quite a lot in a short space of time, but I'd be really interested to find out if any of this resonated with you, and whether you think that that it's possible to train oneself to be more compassionate and less susceptible to empathic distress, whether it's possible to treat oneself with the kindness and compassion that I'm advocating, and whether that this is something that can help in the healthcare space in which we find ourselves, which is characterized by overburdened systems, overburdened patients, and indeed overburdened healthcare providers. So thank you. I'm going to stop sharing and leave room for conversation. Thank you.
Thank you so much, Heidi. That was such an insightful talk. And please, everyone, if you have any questions, comments, please feel free to just raise your hand, and then we'll just take the questions.
If I may, while you're thinking of those questions, I just looked at the chat and see that there was a pretty even split between the thumbs up and the clapped hands, and that really indicates that I think many people can identify that in some situations we do want to alleviate the suffering. In all situations, we want to alleviate the suffering of our patients, but sometimes that involves that over-identification with our patients, as opposed to the kind of attempt to not put ourselves in our patient's shoes. As I've said elsewhere, sometimes when we wear other people's shoes, all that happens is we get blisters because they don't fit us properly. But rather walking with our patients along the path that they have to walk with, focusing on how we can do things together to alleviate suffering, as opposed to being paralyzed by the suffering that our patients feel.
And that is quite great, Heidi. I think Estelle, I'm not sure if you would like
Yeah.
to. Yes.
Yeah, hello, Nwabisa. Thanks for chairing today. We really appreciate it. I just wondered, I mean, clearly you're also working with medical students. What is the best time to start teaching them that? The moment they start working with sick patients? Do you think that's a good moment, or later on? Because clearly we need support. And I mean, all of us know we need support, and we've probably made a way for ourselves. How do we, what would you do if you could do whatever is, choose? If you could do what you think is the best thing?
I think that it is, I mean, I'm biased, of course, because I think everybody should do philosophy, no matter what profession they go into or what plan they make for their lives. And so I think it should be done very early on. I think that we should start with self-compassion. I have seen too many medical students suffer from terrible mental health situations. We've heard the stories, we've seen them, some of us know them personally. I think we need to start with self-compassion, and I think medical students need to break this idea that they need to know everything all the time and be 100% on from day one, because I think that is breaking healthcare, as the topic of my talk said. So firstly, I think we need to teach, we need to get them young. We need to get them self-compassionate at a young age. That doesn't mean that we sort of make everything soft and fluffy and ice creams and unicorns, but I think we need to build resilience from a really young age, from a really early stage in their education. And I think, drawing on Aristotle, it needs to be a constant work in progress. This is not a one lecture kind of thing that, you go and be compassionate or self-compassionate and compassionate towards others. I think this needs to be filtered throughout the medical curriculum. And I think that senior management, so consultants and head of departments, I think they need to walk the walk. Because if we train our young people to be compassionate and to be self-compassionate, and then they get negative feedback when they do that, that's going to be problematic. So I guess I'm calling for a kind of, I sometimes call it a Copernican revolution in the way we teach people, that actually that the health, my colleague Anya once said to me, when I was talking about the moral distress among healthcare providers, he said, it's so weird. Healthcare providers are so good at caring for others and so bad at caring for themselves. And I think that's where we've got to start. We've got to start with the self-care, the self-compassion, and push it all the way through. And then it becomes the norm. We don't have to think about it. It becomes a coping mechanism that has positive outcomes rather than a coping mechanism that has negative ones.
I also think, Heidi, as someone who's also like a student and trained, like working with patients as a psychologist, it's basically like, when you being like high achieving for so long, like taking failure is very hard. Like, you're not as kind to yourself. So when people come to university and then they start failing when they've passed with great marks all their lives, I can imagine the medical students, and then all of a sudden they are actually struggling. It's very hard to be compassionate, self-compassionate in those moments when you're discovering oh, actually, you are capable of failing. So I think also learning that failure is not like a moral failure, like failing is not like a moral thing, but it's actually like a normal thing. Everyone fails at something. It's also an important thing to drill in students while when they get to universities, particularly because they're so used to a certain way of academic performance that they just burn out and they just shut down when they see any failure. So I think that's also part of that sort of self-compassion angle.
I think so, absolutely, Nwabisa. I think failure is such an important life lesson, and I think it's problematic that for many people it comes quite late on. I always laugh at myself because I really wanted to be head girl at my school, and I wasn't. And it haunted me for many, many decades, and I will say decades, because it was the biggest failure. And when I think about it now, I spend so much time and energy focusing on that one achievement that I didn't get, that I didn't think about all the other things. And I think that being kind to oneself requires us to fail. You don't need to be kind to yourself if you're winning all the time or achieving all the time, but that's abnormal. And it puts so much pressure on a person to continually maintain that. So I think the also run, even if you didn't come first, is really, an important lesson. And it's an opportunity to go, okay, I didn't hit the mark that time. What can I do differently next time?
And thank you, Heidi. There's also like a few comments and questions in the chat box. So Charlene said, thank you. This really resonated with me. I learned late in life about spirituality and philosophy and mindfulness. Resilience is such an important aspect of our growth. So if you have anything to add to that, Heidi, there's also a question by Nicole.
Okay, let me just pop, Charlene, thank you for that. I think resilience is important, and I've spoken in the past about resilience, ethical resilience, and I've shifted my thinking a little bit because I used to think about ethical resilience as being the typical definition of resilience is bounce back ability. So can you bounce back to where you were? And I think that is problematic. I don't think we should ever bounce back. We should always bounce forward. And so by failing or not getting what we planned or having a different outcome, if we go back, the next time that happens to us, we're going to be in the same position. We won't have grown. We won't have developed. So I think about ethical resilience as being bounce forward, not bounce back ability, but bounce forward ability, which, as Charlene says, is a really important aspect for growth. So when I was in this position, I didn't achieve what I wanted to achieve then. How do I get to a different position so that I have a better chance of achieving what I wanted to achieve in the next iteration?
Thank you, Heidi. Nicole said, excellent talk. Thanks, Heidi. Do you have any tips on how you apply compassion practically in clinical care? Perhaps some examples, of where clinicians were involved in challenging patient scenarios and responded well, like similar to the examples in the beginning.
So thank you. I work a lot with the oncology radiologists, and I sometimes hear the way that they talk about their patients, and I see it there in that there's a real kind of identifiability that they have with patients. And obviously, cancer is a terrifying illness. And for many people, given the proliferation of cancers around the world, where, it's in many of our futures. And I think that, or presence, and I think that ability to go, to be able to ring fence the moment rather than looking at the future is really important. So, I can think of some examples. I'm worried about confidentiality and situations, scenarios like that. But I think that the response that I've found, the clinicians who I think handle it better handle it in a very sort of pragmatic, practical way. So compassion being very much about, okay, this is the situation now. What is the next step? And only imagining the next step rather than the next 10 steps, or not imagining, okay, you've got 2 years of chemotherapy coming up, but okay, you've got a chemotherapy treatment tomorrow. How are we going to handle that? Or you've got surgery next week. How are we going to handle that? Because I think that when we anticipate the future, it becomes, as I said, very overwhelming. So the clinicians that I've seen who do a really good job are the ones who can kind of almost contain the bad news and kind of make it very present, as opposed to kind of leaping into the future, which is largely unknown or unexpected or too much for a patient to be able to anticipate. So giving small amounts of information, manageable bite-sized chunks, and a very concrete, pragmatic plan of action, I think is really, really important.
Thanks, Heidi. Not sure if Nicole, yeah. Thank you. So Jonas said that should we maybe not start very early to teach medical students about EQ and helicopter view of the real medical world, which includes doctor-patient ratio in both private and public health? Yeah.
Absolutely. I think that I mean, the more work I'm doing with people in the private sector as well, is that there is significant moral distress in the private sector as well. But I think its causes are very different, and I think that this is what's Jonas, excuse me, is pointing to. There's a terrible joke that says, it's impossible to get an ICU bed in the public, to get into ICU in the public sector, and it's impossible to get out of ICU in the private sector, because of the burden on private sector doctors to kind of make money and to worry about the bottom line. But I think that we need to make the public sector, the public health sector, much more attractive to our doctors. I think that, and it's a kind of chicken and egg, until we deal with the empathic distress and the overburdened public health sector, we're going to lose people to the private health sector. And until we stop losing people to the private health sector, we're not going to be able to help the public sector. So I think it requires, and that's why I said, I think, if Estelle said I could do what I want, if I could do what I want, I would take all Elon Musk's money and put it into the South African healthcare system and education system, and then things would be a lot better. But failing a massive injection of resources into the public health system, I think it's up to senior colleagues, medical management, to really make these shifts, to encourage compassionate behavior among staff, there's no value in having wellness programs and teaching meditation and teaching compassion to our staff if, when they ask for time to go and visit a wellness professional or to do meditation, they're hitting a brick wall. And so I don't think it takes a lot of work. A colleague of mine in oncology says that for every Friday morning in their department, they do a 10-minute yoga session. And she says that it really helps them decompress from the week's work. It helps them kind of go into the Friday feeling positive, feeling happy, which then spills over into their weekend. And so it's a 10-minute collegial, collaborative space that they have carved out for themselves, and I think really makes a significant difference. So I do think we need to start with small steps, incremental steps, to really shift the way we do things, failing a massive injection of resources and expenditure on the public healthcare service.
I completely agree. Thank you, Heidi. Rita says that I also think that medical students should be exposed to transcendental meditation early to help reduce burnout.
Agreed. The more tools, and the thing is that not everything works for everyone. My colleague Jantina de Vries has been trying to get me to meditate for about 3 years, but I'm too impatient and I have ants in my pants and I can't sit still and meditate. And so it might not be that meditation works for everyone, or seeing a trauma counselor helps for everyone, or walking around the block helps for everyone. In fact, there was a study done by an American social worker, and he looked at an English social worker, Fleming, and he looked at a whole lot of different kinds of actions that are supposed to help burnout or reduce burnout. And the one that had the biggest effect was walking your dog. And so if you are able to have a pet, for some people, walking their dog, it's about getting fresh air. It's about meeting other dog owners and kind of laughing about your dog's behaviors and things like that, whether it's a cat or a bird or a pet rat, which I've heard pet rats make excellent pets. I think finding what works for oneself is really, really important. And I've tried to, again, accept that my failure to meditate is not actually a failure. It's just not for me. And so it might take more than one attempt to find the right sort of thing. But I think Nanette's point about a trauma psychologist is so important. I think recognizing that there is an issue is so important, that and not being ashamed that one is feeling burnt out, or embarrassed that one is feeling empathetically distressed, or anything like that, I think is fundamentally important.
I also think sometimes there's that stigma that might prevent people from seeking help from a trauma psychologist, for example. If you in the health professional space, because you expected to be able to take it, all of that burden, everything supposed to be stronger than the whole problems that you're presented with because of the overburdened health system. So sometimes people are stigmatized, and sometimes it's culturally, actually, because you're not used to this. You don't know these avenues are open to you. You can go see a trauma psychologist because you've never actually experienced that. So it's people are not really aware that there's certain things that they can do to help themselves. So it would be great to have more awareness about mental health that is more widespread in the health professional space too.
Yeah, and I think we had an opportunity during COVID and immediately after COVID, where mental well-being was so central, both of the general public, but also of healthcare providers. We really, really kind of put mental health front and center. And I see it with young people now. We talk about mental health, and we talk about the effects of social media on one's mental health. And we have to destigmatize this idea that mental health somehow is for weak people, or for people who can't cope, or people must learn to suck it up or be tougher. I think that, yes, maybe healthcare providers historically have had this kind of aura of being tougher than the rest, being able to cope than the rest. But I don't think that the situation, when you have a healthcare system like ours, which is so overburdened, how can suffering be normalized? It can't. And so we can't treat what goes on in our hospitals and in our clinics as normal. And so as soon as we recognize that it's not normal, we have to take the step of getting help, whether that's meditation or jogging or seeing a trauma counselor.
I agree. Thank you so much. Does anyone have any more questions? Please feel free to raise your hand or just unmute. Okay.
So I will say that we're expanding this work, and Nwabisa is helping me. It is to look at the levels of there isn't a significant amount of compassion training course, or a number of compassion training opportunities in South Africa. There are a couple of online ones. There's a Monash compassion course for healthcare workers, which is an asynchronous, so you don't have to get up at some ungodly hour to meet with Australian time. But there is that course. There's another one offered, I think, by the University of San Diego, UC San Diego, University of California, San Diego. So you can check out these online courses, but we're hoping at the Ethics Lab, and with help from people like Norbisa and other people, we're hoping to be able to offer a compassion training course in the not too distant future. And so if the people want to check out the ethics lab in sort of middle of next year, we should be able to be offering tips and training for developing compassion, as opposed to kind of the detachment or empathic distress. And we're doing some research on that, and hopefully practicing on some brains to see what exactly is going on with the neuroscience.
Yeah. If there's no more questions, Heidi, I think that's a great place to land, because you spoke about the future, and usually with every presentation, everyone wants to know, okay, what's the way forward from here? So thank you so much, Heidi. That was a really insightful presentation, and it was great to learn about philosophy, meeting with neuroscience, everything, because everything is a thought before it becomes anything else, and that's philosophy. Love philosophy. Okay. Oh, I think someone has a question. Oh, Jonas, yes. How
Yes.
far is AI close to closing a gap which will allow doctors to treat patients remotely and robotically?
I hope very far, Jonas, because there was a wonderful article. In fact, I've got it. I've been reading it over and over again, written in The Guardian by a psychiatrist, who, which was entitled "What We Lose When We Surrender Care to the AI." And I think that we really need to be careful about this, because I think that can distort the profession. I think that AI can be excellent in training us to be compassionate. I think we can use ChatGPT and Claude to say, how can I be more compassionate and less empathetic? But when we start using AI to treat patients, I think patients lose out. And I think that the reason for going into healthcare, which is that human touch, we're going to lose out. So my answer to you, Jonas, is I don't know how far, but I hope it's very far.
Me too, because as a health professional. So I think there's no more questions. I've looked everywhere, but yeah. If anyone else has any questions, please feel free to contact Heidi via email if you would like more clarification or want to know more about the compassion versus empathy work that she does. But yeah, for today, I think that's all. So thank you so much for joining. And please have a lovely day. Continue with the rest of your day. And thank you so much to the team, to the deep dive team, Estelle and Nicole. Thank you so much for the opportunity, and yeah, really grateful.
Thank you. Thank you so much, everyone. Have a lovely evening.
Thanks for a great session. Cheers.
Bye.
Thank you.